Priya.
Great, great. Good evening and welcome to you all for today's webinar. Thank you very much for supporting both CME and non-CME webinars of National RP. Today we have very good webinar, mental health and stigma in South Asians. We would like to invite our today's moderator, Dr. Amy Bakshi. She is our Young Physician Section President of National RP and practicing psychiatrist in New York. I welcome Amy. Thank you.
Thank you. So I'm very excited for tonight. We have three wonderful speakers who I just can't wait to hear speak tonight. So I want to start by, just a couple words before we let them speak. But I entitled this talk, Mental Illness and its Stigma in South Asians. And I talked about South Asians in general because the South Asian population is inherently diverse. However, the common thread amongst us all is that there is a stigma towards mental illness, which unfortunately still exists for numerous reasons. And there remains a stigma in the society that we trust so much, but it's also the society that judges us the most. So the consequences of not addressing this medical issue, and I do call it a medical illness, can be pretty dire. So in order for us to learn more about this today as a community, we've brought together these three incredibly passionate, brilliant women in honor of National Women Physicians Month too, to enlighten us with their experiences today. Tonight's event stems from a very tragic event that occurred in our community earlier this year. Nima Bhakta, a young lady who had just given birth to her 7-month-old baby boy, took her own life in the context of postpartum depression. Because of the courage of Nima and Priya's family, this initiated a movement that has been powerful in addressing mental health in our community. We are so humbled to have Nima's sister, Priya Bhakta, here today with us to tell us about her firsthand experience. So if we could, I'd like for Priya to get started.
Hi, I'm Priya. I'm Nima's sister. I first wanted to start off by thanking all of you for joining on this webinar. It means a lot to me and my family. Our passion has become, to share my sister's story. It's a big part of how we are grieving with this, with her loss. So thank you, all of you, for joining on this call. I first wanted to talk about who Nima was before she became known for her postpartum. She was very loving. She was a perfectionist. I honestly can't think of anything negative to say about her because she's just always been so perfect. She lived a very simple life. She married the love of her life, was very excited to be a mother. And we come from humble beginnings to, we were raised in a first-generation immigrant family. So I feel like most of us in this room have a little bit of experience of coming from, being raised in a home where parents were first-generation immigrants. I think a lot of the stigma around mental health stems from just all the journeys and all the hardships that our parents and our family members went through in order to survive and create a life here in America. Nima loved her son. I really wanted to point that out. She was obsessed with her son, and ultimately her sacrifice was for her son. So I really wanted to push that point across because I don't want it to seem that she left or she did this and abandoned her son, because it's quite frankly the exact opposite. She was the best sister. I will always pray to have her as my sister in every lifetime. And I just want to thank all of you for, again, taking the time out to listen to her story, and if anything, raise awareness and continue, and please pass the message along, pass the story along to everyone in your own families.
Thank you so much, Priya. So, you know, and we'll get probably a little bit more into Priya's story as the evening progresses. But in order to kind of take the next steps, it's really important to educate ourselves about what we're looking for that can be the first step to both prevention and treatment of perinatal mental health. So in that light, we have Dr. Haritha Raja, who's an accomplished reproductive psychiatrist who founded Bethesda Women's Mental Health in order to reduce the stigma of treating women in and around pregnancy. So today she joins us to share her expertise. Dr. Raja.
Thank you so much, Priya, for sharing your story. And I'm just humbled to be here with you. And thank you for having me. I'm just going to go ahead and share my screen if I can. Give me 1 second, sorry. Looks like it should be up. Great. So my hope today is to tell you a little bit about perinatal mood and anxiety disorders. They are a various group of mood and anxiety disorders that occur during pregnancy or actually up to the first year. You know, for our physicians in the DSM-5, we look at postpartum disorders and they say only up to the first 4 weeks. Unfortunately, that is just based on the data that's been obtained, but in reality, in clinical practice, these disorders do come up to the first year. So why do we talk about perinatal mood and anxiety disorders? In fact, perinatal mood and anxiety disorders, which I'm going to refer to as PMADS, are actually the #1 complication following childbirth. And as we've discussed, can have really dire consequences when untreated. So I want to actually start from talking about baby blues. So baby blues is actually not a disorder, but we often hear about it. About 85% of women will have baby blues, where they have sort of just a little bit more than the normal daily fluctuations. So they may be a little more weepy, a little more irritable, sometimes some resentment toward the husband more than usual. And these symptoms often come up in the first 10 days. And then can last up to the first 2 to 3 weeks, but they are mild symptoms. So if we see anything more than mild symptoms, we're not talking about baby blues. The common misconception is you have to have baby blues to have postpartum depression. It's not true. If you have baby blues, you may not have postpartum depression, and if you don't have baby blues, you can still have postpartum depression. So postpartum depression, what is commonly talked about in the media, it is a very prevalent disorder and it does not discriminate. So 1 in 8 women across the general population will have postpartum depression, and in South Asians, that number is much higher. And it's very unfortunate because South Asian women have a very high likelihood of having depression, but their utilization of mental health services is one of the lowest among all ethnic groups. So usually postpartum depression sets in the first 1 to 6 months, but like I said before, can last up to a year. Initiate within the first year. Unfortunately, 50% of these women will be unrecognized or undertreated or untreated. So why are these women not picked up right away? Well, one of the issues is that postpartum depression is not always presented as crying. So some women will cry, other women will not. Other women will be more anxious. They may feel hopeless. They may have breastfeeding difficulties, and they may feel really irritable. And a very common symptom we see is a change in sleep. So if you ask a new mom, are you sleeping? They'll either laugh or hit you. I don't know, one or the other. But the question we really need to ask is, are you sleeping when the baby is sleeping? And that is a very important question to ask our new moms to see how they're doing postpartum. So one of the questions that we often get is, where does postpartum depression come from? And postpartum depression has many possible etiologies, but what we do know is that it is a perfect storm. Women are, especially new first-time moms, are entering a new role of being a wife and a mom. We have sleep deprivation, hormonal changes. And so one of the changes that we see with regards to the postpartum period is a temporal sudden change in estradiol and progesterone levels. Interestingly, the women who do present with postpartum depression do not have lower concentrations of estrogen or progesterone, and they don't have a quicker decrease in estrogen or progesterone. It's more that they're sensitive to the changes that happen in these hormones postpartum. The other possible etiology is through neurosteroid impact. So neurosteroids modulate GABA and glutamate, and two of the most common neurosteroids that we talk about in the postpartum depression is dihydroepiandrosterone and allopregnanolone. So DHEA has been used in people who have depression effectively. And I am so excited to tell you that allopregnanolone, actually a metabolite of progesterone, and we have found that there is an FDA-approved medication for postpartum depression for the very first time, and that's brexanolone. If anyone has questions about that, I'm happy to answer it later, but I'll just move on for sake of time. So postpartum anxiety disorders are often not as talked about as postpartum depression. In fact, these postpartum anxiety disorders will be as common, if not more common, than postpartum depression, and they can present in many ways. So women who are postpartum may be general worriers, and that would just be postpartum anxiety in general. We also see postpartum obsessive compulsive disorder. So these women present sort of differently than general obsessive compulsive disorder, in that the intrusive thoughts revolve around the baby. So thoughts are often about hurting the baby. So I've heard many women come in and say, I thought I was going to fall down the stairs and hurt the baby. Or if they live in a high rise, I thought I was going to throw the baby out the window. Or when I'm around knives, I think I'm going to hurt the baby. The big difference with someone who has obsessive compulsive disorder postpartum versus psychosis is these thoughts are ego dystonic. And what that means is these women do not want to hurt their babies. They're actually very scared by these thoughts. And that's why they actually feel sometimes that they can't talk about it. They think that their baby is going to be taken away. But we know that we have treatments, and it's a very common disorder. We also see postpartum panic disorder, which is very similar to panic disorder in the general public. So, having extreme anxiety that can be with or without a trigger. There are physical symptoms that occur: shortness of breath, chest pain, dizziness, can have increased heart rate, and often women feel like they're going to die. The panic disorder actually comes up a lot in pregnancy as well. And the reason is the hormonal changes can sometimes trigger a panic attack. And then post-traumatic stress disorder, often not thought about in the postpartum period, but actually very common as well. So women who have either a history of trauma or a traumatic birth, and we only know if we ask them, can have intrusive thoughts and repetitive thoughts about their trauma. And they often then go to great lengths to avoid certain reminders of the trauma. So for example, a woman may not go back to her OB or want to enter the hospital in which they delivered because there was such a significant amount of trauma that led to their PTSD symptoms. And of course, I have to say a word about postpartum psychosis. Postpartum psychosis is a psychiatric emergency. It is rare, but it must be treated upon recognition. And generally, it's in the first few days that we see these symptoms come on. And if not all, will happen in the first 2 weeks. And the primary risk factor for these women is actually a history of bipolar disorder or a presentation of bipolar disorder that will occur after the fact of postpartum. So these women do have a break with reality. They often have fixed false beliefs or delusions. They will talk about hearing things or seeing things that aren't there, or hallucinations. And these women are not sleeping. They're not sleeping, and they have a lot of energy. So, I think it's really important to just take a moment here and talk about what we see in the news with infanticide. So the women who kill their children, and often the media depicts these women as having postpartum depression. These women do not have just postpartum depression. They were psychotic. They had a break with reality, and so it was postpartum psychosis. So how do we assess women, whether in pregnancy or postpartum? It would be with the Edinburgh Postnatal Depression Scale. It's a gold standard, or the EPDS. This is a pretty quick questionnaire, 10 questions that can be administered in the office. And is very helpful. Usually we look at a score of about 12. If 12 and over, we would like to get further assessment. And then of course, I can spend all day talking about treatments, but I just, if we don't learn anything else today, just know that these disorders are treatable, that women can get better, and that, it starts with awareness, but there are many different treatment options. So of course, kind of at the most conservative level, just support, family support, peer support. There's also psychotherapy that is evidence-based for postpartum symptoms. So we have cognitive behavioral therapy, interpersonal therapy, and then medications are relatively safe for pregnancy and postpartum. And so we can use antidepressants, anti-anxiety medications, mood stabilizers, etc. And here are just some important resources that can be used. And these are mostly for our physicians. They can provide really important information about medications in pregnancy and postpartum. Thank you.
Thank you so much. That's obviously a lot of information, but she has offered to share those slides with anybody who may be interested. So feel free to reach out if anybody is interested in further information about some of the details that she just shared. In order to bring Nima's story together with the information behind the medical illness, we need to further incorporate the impact on our community. And this applies not just to postpartum depression, but really for all mental illness. So Divya Kumar joins us today. She's given women of color a place to be heard as the co-founder of Perinatal Mental Health Alliance for People of Color. She better understands the root cause of the stigma and plans to share more with us today. Divya?
Thank you so much. It's so wonderful to be here and to be a part of this panel with all of you amazing women. Let me share my screen and I will get started. Share. I'm sharing my screen. Okay, here we go. All right. Okay. So I'm going to pick up where Dr. Raja left off, and I'm going to talk a little bit about barriers to seeking and receiving help, and I'm also going to weave in some of the cultural pieces that I think are particularly relevant when we talk about perinatal mental health in the South Asian community. So like Dr. Raja was saying, PMADS are the most common complication of childbirth, right? If they're so prevalent, why is it so hard for new moms to say, hey, this is hard, I'm struggling, how can I get some help? Some of these barriers are true universally, and some of them are more true in the South Asian community. Stigma, right? We don't talk about mental health. We don't have mental health issues. We don't want to draw negative attention or shame to our families, to our communities. We don't want to air dirty laundry. Sometimes in some Desi communities, everybody knows everybody else's business. There's a lack of privacy. We may not know about perinatal mental health. Like Dr. Raja was saying, there were so many different presentations and we may not know about all of them. And that's also why we're here. There may be a lack of family support around seeking help. Many of us may live in multi-generational homes, have somebody coming to stay with us after the baby comes. That person may love us so much and may minimize our concerns and may say, oh, you're going to feel better when you hold your baby. Don't cry, it's a happy time now. You just need to eat more food, you need to rest. There are so many myths about motherhood and a lack of representation of the range of experience of what motherhood can be. Having a baby is supposed to be joyful, something we celebrate, right? We wait our whole lives to get married and have babies, and then there isn't a discussion about, oh, you might feel sad or you might feel worried, right? So if we don't hear that somebody isn't happy, they didn't bond with their baby right away, and that happens to us, we've never seen that part of motherhood before. So we may feel like there's something wrong with us. We may have misconceptions about the mental health field in general. Why would I go talk to a stranger about my problems? Also, there's a lack of South Asian therapists, and this is something that the Perinatal Mental Health Alliance for People of Color is trying to change by providing scholarships to folks of color, and particularly Desi therapists, and I'll get to that more in a minute. It can be really helpful to see somebody who has the knowledge about your culture, because when your body is broken from having a baby and you are tired and worried, the last thing you want to do is work to explain something that's important about your culture to a stranger. I think that it's important to talk about the cultural pieces here, and I want to sort of, I have my little onion picture here to like peel the onion back a little bit, because it's worth digging into this to think about what we carry with us that influences how we see ourselves, how we understand motherhood, how we understand ourselves as mothers, whether we think we're good mothers, and how we may treat ourselves if we're struggling. And, you know, I think that sometimes we do have family members who are like, okay, let's get you help, and that's very good. But if we have all of these narratives that we've lived with our whole lives, it can feel like we're pushing a stone up a hill to get out from under them. I also don't want to pathologize our culture. I'm not saying that we're broken. I'm just trying to say, like, let's look at what we've learned so we can try to make sense of what's happening and to sort of put our reactions in a context. The normalization, glorification of struggle and suffering, especially for women, it's ingrained in our view of what an ideal woman or wife or mother is like, right? Long suffering, accommodating, living for others. Love is sacrifice. We put our families first, even at our own expense. Being a mother means taking care of your children first, not focusing on your own needs. The idea that thinking about ourselves is sort of selfish, right? That's more, we're not like Americans who just think about themselves. We're family oriented. We think about our children. So if we focus on how we're feeling, we might not be a good mother. We're also raised in this collectivist society. We define ourselves relationally through each other, through our families. So there's this Western idea, oh, if mom is happy, everybody's happy, or happy mommy, happy baby. But that's not how I was raised at all. It's more of, if the family and the baby are doing well, then mom has done her duty and thus has succeeded. I was raised with the Hindu concept of dharma woven very, very heavily into my life, right? And so this also comes back to the importance of culturally responsive therapy, because if I'm struggling as a South Asian mom and I'm like, I have to do my duty to my family, I have to take care of my baby, and I go see a therapist who doesn't understand this, and they're like, you need self-care, take care of yourself. I'm like, you don't understand where I'm coming from. That can feel alienating. Along these lines are the immigrant narratives that we were raised with. We came here with nothing, so you could have everything, so you need to be grateful for everything you have. They sacrificed so much, they worked so hard, so the only feeling we can have is gratitude. And we may feel guilty and ashamed for feeling anything else, and that may prevent us from seeking help. Many of us may have grown up hearing, you have a house, you have clothes, you have food, what's the problem? So we internalize that and we say, oh, I have a healthy baby, so what's the problem? Why am I sad? And then it's, if I'm sad or unhappy, then there must be something wrong with me. So if we have it all and we still feel bad, we can feel like we're letting our families down. They did so much for us, they loved us, and something isn't right with us right now, so we must be doing something wrong. We may be failing the people who love us and sacrifice for us. I know that you physicians know this also well. We white knuckle, right? Just gut it out, right? Work harder, try harder, pull yourself up by your bootstraps. Again, this creates more shame, more self-blame for somebody who's struggling with a perinatal mood or anxiety disorder. And it may exacerbate symptoms of anxiety or OCD. That mom doesn't need to try harder or push herself harder. That's going to make her symptoms worse. And again, another plug for culturally responsive therapy. Many of you might have heard of the good enough mother, a psychodynamic guy, Winnicott, like the baby needs a good enough mother. We Indians, South Asians, there's no good enough. We have to be perfect. This good enough mother concept is very foreign. Also, it's worth mentioning the model minority myth, which is less of a narrative, but more something that I think that our culture has internalized from capitalism and white supremacy. It boxes us in. We have to be quiet. We have to do our jobs. We cannot speak up. It puts a tremendous amount of pressure on us to always succeed and never fail. So where does this leave us? we live on this emotional house of cards, right? We're raised to be happy through our relationships. We define ourselves through our relationships, duty to family, being good mothers. So if we feel like we're not doing it right, we are not good enough. We feel painful emotions. It's a quick jump to feel like we are failing. We are not good mothers. And there's nowhere else for us to go emotionally except to guilt and shame. We also don't have practice naming and talking about feelings. We're terrible at this. It's hard for us to name them for ourselves. Emotional learning, we teach our kids to read, write, count, ride a bike, etc. We also should be teaching them words for feelings. Many of us weren't taught these words. I actually, disclosure, see a Desi therapist, and it took me seeing her to realize that we don't have feelings for many Indian languages. And many of us don't grow up having our parents say, oh, it looks like you're sad because the store is closed, or, oh, you must be very angry because your sister took your toy. We didn't have that narrative. So if we don't learn by having somebody teach us, validate our feelings, if we're postpartum and we're having a whole bunch of feelings, it might be hard for us to connect the dots for ourselves, especially when we're in crisis. Again, the children of immigrants piece, navigating a bicultural identity, we often have to bushwhack and figure out how do we reconcile and honor what we were raised with, and also figure out how to live in an emotionally sustainable way. I was born in the US. I'm very sort of non-traditional in certain ways, but the narrative of sacrifice and feeling like I had to be grateful and suck it up was very strong for me. And those of us who've done work around our racial identity may, in motherhood, be kind of blown back into more traditional and toxic elements of our culture, and that can feel very destabilizing. So here's our house of cards. Look at this cumulative effect. We may not know how to name feelings. We may not know how to understand they're okay, they make sense. Our families, our communities may not know how to talk about this. We may hear all this, don't worry about it. What's the point of being sad? Stop crying. Don't worry about it. Your baby's healthy. That's what matters. Lack of support around seeking mental health support. Lack of basic therapists and culturally responsive care. All while we're postpartum. We're crying. Our bodies just grew a baby and birthed that baby. It's a lot. It's a lot to carry. So what I offer, Dr. Raja mentioned the evidence-based therapy models. And in addition to that, I like to offer Desi moms a process of recreating some of these narratives and to learn how to hold multiple truths and embrace the both and hold multiple things at the same time. So instead of my parents came here and sacrificed and suffered, so I have to be happy and grateful, we can say, I'm grateful for all my parents did for me. And also I'm having a hard time adjusting to motherhood. We can be grateful for our babies and also not enjoy every moment. You can be happy to be a mother and also have worries. You can take care of your baby and your family and also attend to your own feelings and needs. You can re-examine how you were raised and also honor your culture. Very quickly, I just wanted to mention for folks who might know somebody who's struggling, a family member, if you come away from this talk and you're like, I wonder if this person I love in my life is okay. If somebody approaches you and says like, you know, you see somebody who doesn't seem quite like themselves, you see them crying, you see them withdrawn, they don't seem, you know your loved ones, do they not seem like themselves after they had a baby? It's okay to ask, how are you doing? No, how are you really doing? If somebody wants to tell you something, if she wants to share, listen without explaining, without invalidating. If someone's trying to tell you something, listen. You may want her to be happy. I want my children to be happy. And if they're not happy, I need to hear that and not say, oh, no, it's fine. I want them to be fine, but maybe they're not. Normalizing, validating, practice what you might say based on all the information that Dr. Raja gave you. You know, feeling sad and worried is something that many moms experience. This is very common. We're not used to talking about this. It's not easy. Many moms experience this. I'm listening to you. You can share your own experience if you struggled, but we just don't want to give a lot of advice. Make sure you do this, don't do that. That's not necessarily helpful. The idea here is about validating, reducing stigma, and decreasing emotional isolation. And you can help direct somebody to resources. Postpartum Support International is a huge international organization that specializes in perinatal mental health. There's a helpline you can call or you can text. For physicians and providers, there's a perinatal psychiatric consult line that is free. And you can get advice on clinical issues prescribing for perinatal moms. I know folks often have questions about that. There's a provider directory. You can find a provider in your area. We have support groups that I'll share with you on the next slide. The agency that I founded, the Perinatal Mental Health Alliance for People of Color, is part of PSI. We offer scholarships for providers of color, so we have more of us. And we're getting ready to introduce the Nima Bhakta scholarships specifically for Desi providers. And part of one of the initiatives that was created to honor Nima's legacy and life was a Desi support group. It's a monthly free support group online for South Asian moms. It's going to be facilitated by me and another therapist in California. And that's what I have for now. We're so excited about this new resource so we can all come together and talk about the real things. So that's my bit. I will.
Thank you, Divya. Thank you, thank you, thank you. We're getting great feedback. There's a lot of people who are very excited about what all three of you have shared today. You know, I think this is a really great time for us to reinforce Nima's life's legacy is going to be carried on, right? And I think, Divya, I think that's what you were trying to point out here. And a lot of this is being done in her honor. So, but yeah, I think it's important for, you know, you and your family to know that this is really important to all of us, and your courage and, despite grieving the significant loss right now, it's still happening. The courage to speak about this right now is really humbling to all of us. So one of the questions that's been coming up is, you know, and I think, Bria, you kind of talked about this in the chat a little bit, is the stigma behind medications. So a lot of people do question, wait, I don't want to take medications, I'm pregnant, or I want to get pregnant, I want to come off of my medications. We often see patients who say, you know what, yes, I have a history of depression, but I want to have a baby and I don't want any of this medication to go into my baby. And then, or you become pregnant, you develop this, and similarly you're wondering, even if it's that 0.01% chance, you know, you don't want to harm your baby in any way. And part of this is our culture, right? How do we address that to these new moms? What do we do? How can we talk to these moms and say, there is so much evidence that shows that the treatment is so much less risky than you being a depressed mother? And I can address this to any of you guys, honestly.
So I can say a word to this because this is what I do day in and day out. And I will say that someone actually brought up a great point, and I'm just trying to get to it. Let's see. Mr. Vasavada was, you know, talking about this in the chat. What we often don't talk about is the risk of depression and anxiety on the baby and the impact it has in pregnancy and postpartum. So we often think about just the difference between being on medication and being off of medication. And so I think it's really important for us to discuss the impact that depression and anxiety have on the baby. So we know that there are complications that occur obstetrically. We can have premature delivery. We can have impact on bonding with the baby, all from depression and anxiety themselves. And the medications we have are actually relatively safe. And of course, we talk about the risks and benefits, but I think unfortunately, the inherent problem when women are depressed or anxious is that they are not able to think as clearly or rationally as they would when they weren't. And so their decisions are really skewed based on kind of what's going on in their mind. And so this is where we try to use family support, and we try to discuss, but at the end of the day, we really have to try to build a rapport with our patients. And sometimes they're successful and sometimes we're not, because the amount of stigma that's been built around medications in pregnancy and postpartum has been very significant throughout the years.
Thank you. How often, Divya, do you see moms who, you know, say, because, you know, my mother-in-law would never let me take these meds, or my husband, I don't need meds, like, I'll be fine. You know, nobody in India would ever think this is okay. You know, how often is it that that cultural element comes in the way, and we can't do anything about it? Like, what can we do when the family or the patient is saying, absolutely not, I can't do this because of the cultural component? You know, one of the things that we were talking about earlier was that there is, of all the racial and ethnic groups in our country, Asian American females between the ages of 15 and 24 have the highest suicide rates. Suicide is the 5th leading cause of death in South Asians and the 9th in Caucasians. So clearly there's a disparity, and there's also a disparity in the use of resources, right? Divya, how often do you see that? And what are some specific things you can say to South Asians that are different from what you say to somebody who may not be from the same culture?
That's a great question. And I do see this. I absolutely see this as like, oh, we don't really do that. I don't need medication. That sounds, and I will also say that so there's a couple things I do. One, I contextualize it. I often contextualize PMADS in relation to something very common like gestational diabetes, right? Everybody's screened for GD during pregnancy. You drink that nasty orange stuff and you shake for like 2 hours. It's a normal part of pregnancy screening because GD is a thing. It's a medical issue. We screen for it. We treat it, right? PMADS are like twice as common as GD, maybe not quite as common, quite that much, but they're much more common. We don't routinely screen and we don't routinely treat, but there is validated screening and there is safe and healthy treatment. So sometimes I compare it to like, you would take insulin if you needed it, or you use your inhaler when you have an asthma attack. And so I try to like make the comparison. But the thing that I find is I find it's really helpful because it's helpful to sort of say like, what's going on here? Where did you learn that you couldn't take this? Where did you learn this, that like, I should be able to do it by myself? More than like what people in India don't do this. I see this, I have to gut it out. I can do this. I just have to try harder. I'm going to try harder. And that to me breaks my heart because I'm like, this is not studying for an exam. This is not trying to pass your boards. This is not trying to get a promotion. This isn't trying, this doesn't work that way. And so if I just come at it like, no, 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 listen to me, I'm not going to get anywhere. That's why I feel like I spend more time peeling the onion and sort of figuring out like what brought you to this thought pattern. Where did you learn this? And then if you take medicine, what will happen? You can do a little bit of CBT. And what will that mean? Oh, I'll be a bad mother. What does that mean? What do bad mothers do? What is the evidence that you are a bad mother? What does a bad mother look like? Where did you learn that? That's why I really think that talk therapy, and I'm sure, Haritha, you would agree that like talk therapy in combination with medication is such a great way to go because then somebody has a place to explore all of this.
Thank you,
I
Divya.
absolutely agree. And I would actually say that for women who have mild to moderate symptoms, they don't even need medication sometimes.
Sure.
And that the therapy can be so effective, but it can't be therapy with a family member, right? It's a therapy with a clinician who can really provide that non-judgmental arena and treatment that these women need.
Bria, how much of this is resounding? How much of this sounds familiar from what you experienced after your nephew was born?
So this was all uncharted waters for all of us. We knew she wasn't herself pretty much from the day she came home. I live across the country from her, but we're very close. So my mom had actually brought it up to me first that she doesn't seem like she's herself. So my mom's like, you're going to have to come here. You know, we all have our own families. I've got 2 little kids of my own. But you make it happen. That's the best part of Indian communities is we all try, and if there's a problem, we all try and work together to resolve it. This was just like that. She had something wrong. Let's work together to help her and figure it out. I flew there. I noticed immediately, my mom was right. My brother-in-law was right. My sister, everybody. And we tried to work with her, but we weren't aware of everything we could have done. We took her out to eat. We would try and make her favorite food. She had all the help she needed around her. But in her case, it made it harder for her because she had overwhelming love and support around her, but she couldn't get these thoughts out of her head. So, we got in touch with therapists. COVID got in the way. everything was done telephonically. In my experience, body language is so huge when you're trying to, you know, be so raw with a therapist or anyone for that matter, and only so much can get across through a phone call. So we dealt with that. My parents, you know, they tried to switch. She was breastfeeding. They tried to help her, you know, just to formula feed and, you know, assure her that she was okay. It's okay to, you know, give formula and you don't have to, you know, breastfeed. There's no right or wrong. My brother-in-law and his entire family, you know, God bless them. They had so much patience. They had a lot more patience than I've seen around, and they worked with her, they helped her, but ultimately there was nothing we could do because we didn't know what was going on, and what we knew something was wrong, but we didn't know it was to this extent. We didn't know it was like this. She refused medicine. She would tell the doctor she was okay when really she wasn't. So my brother-in-law actually had to intervene and tell them, you really need to tell them what's really going on. And so she was prescribed medicine. I'm not sure which one, but she was prescribed medicine, but she wouldn't take it. She wouldn't take it because she was afraid of the 0.01% of it passing through her breast milk. So
like you said, it's because she loved her son so much, right?
So much, yeah. She really did.
Yeah, that's so important to emphasize. And you know, you bring up a really good point. You said your brother-in-law had to intervene. He was involved. You know, and there are a lot of people who are not females on this call, and it's important, you know, not just for your patients, but also your significant others, your daughters, your daughter-in-laws, you know, your sisters, whoever it may be. You're going to see people around you who have children, and it's important to recognize and appropriately intervene, like your brother-in-law so, you know, thoughtfully did.
Yeah.
And that's so important to, you know, reinforce to our community that it's okay for the families to intervene and help.
Yeah, definitely
guide these moms through the process. Yeah. You know, there is a question about brexanolone. Dr. Raja, if you want to address this a little bit more. The question is about cost. When do we give it? How long does it help? The ongoing treatment regarding brexanolone, and if it should be used with other antidepressants after the infusion.
So,
you want to address that?
It's a great question. So brexanolone, like we were talking about, is a neurosteroid analog that is allopregnanolone, you know, an analog of allopregnanolone. It actually is an IV infusion. So these patients have to be in the hospital. So that's been a big barrier for getting this medication. So it's been used mostly for severe postpartum depression. It is a 60-hour infusion. It's very expensive. I want to say $34,000. I think a lot of psychiatrists, especially reproductive or perinatal psychiatrists, are working on with insurance companies, but it has been a barrier to women getting this treatment. And that actually brings us to, you know, that is one barrier. And the other one is actually there is a lot of, or some women can get syncope from it, and there was a case of a woman having suicidal ideation from the brexanolone itself. So I would say those are kind of the main side effects. Because it's an IV infusion, there's what we've found really exciting is this new medication that's not on the market yet, but that's showing great promise, which is zuranolone. And that actually is an oral medication, so it has oral bioavailability. And we have seen that, as you may or may not know, SSRIs can take 4 to 6 weeks to work. Zuranolone is showing that it can take just a few days to really have an impact. And this would be used for depression in general, but also for postpartum depression. Again, an analog of allopregnanolone. I think, let me just see if there was other questions. Yeah, if there's any other questions, I'm happy to answer. I think I answered most of them.
Does anybody else have any questions? Feel free to either ask on the chat, or you can raise your hand as well, and we can unmute you as well. I see somebody. I see Atul Shah. Let's see if we can unmute you. All right. Let's see. Can you unmute yourself? There you go.
Yeah. Good evening, ladies and gentlemen of the group. I was quite excited. I may be useful with my knowledge about postpartum depression or not, but if you got a few minutes, let me just give you a summary of my experience. I was very fortunate to be associated with mother and baby unit in London, in North London, when I trained in 70s. So it was in 75, 76 that I came from Glasgow to London for training at Tavistock Center for Human Relations. And I was fortunate to have none other than John Bowlby as our teacher there. And the bonding and attachment were all in very much prime time. And I think eventually it was one of the, at the London hospital, they started the group called Mercer group that was based in France, and that was the start of the postpartum depression treatment. And it was puerperal psychosis, puerperal depression, postpartum depression, but it was pretty much a very eventful experience because we had the unit where we actually admitted mothers with severe depression and psychotic depression, and we treated them with ECTs, where we would have nurses, OB/GYN nurses, psych nurses, and internal medicine nurses in a home-like situation. So it's like two-story home, where we would have 4 to 5 mothers with their babies. They would continue to breastfeed while they would go for ECT, come back, have therapy, and all kinds of stuff. Now this was most severe, of course, and you had opportunity for the outpatient treatment and such. And when I came to US in mid-80s, I tried to implement such beautiful kind of concept. It wasn't easy, of course, and it's not an easy concept, except if you have a National Health Service, so people can actually buy that idea, and government funding and all that is available. But it's not possible when you're looking for profit. So really, I think this is more exciting for me to hear. And I haven't attended any lectures because I retired basically, except I've worked here and there for the past couple of years. But that is one of my passions, postpartum depression and treatment thereof. And in Jacksonville, Florida, where I'm based, I have had numerous patients referred to me. I had another colleague here in this area who was also interested in this, because it's very rare that people take on this, and like they botched the whole situation by buying into the stigma, buying into the lack of opportunity to really help them, lack of the therapists who can identify with the culture. So actually, this is wonderful that I finally see something shaping up, and this is kind of dream come true. I didn't know. It just, when I looked at API, and I get mail because I've been a member of API for centuries. And so it really was very exciting to see that I have opportunity to hear new concepts. And I'm sure there are so many new ketamine and all kinds of other, but ECT still remains the prime time treatment for severe depression, suicidal depression. And I've continued to do that. Even though I retired, I continue to do ECT every week in the hospital where I started the ECT program for past couple decades. And I do believe that there is no treatment that can match ECT. And if somebody wants to give me a contest about this, then I'm willing to take on, because I've got the experience of 4 decades plus in ECT from England to US, and still nothing has beaten to the notion that ECT is most effective. And I didn't hear anybody mention that, so I just wanted to just throw in. But thank you so much for this opportunity. You're doing a wonderful job.
Thank you so much for those excellent comments. I agree, there are very limited mother-baby units in this country. I think the 3rd one just opened up last year, so we have very few resources that allow psychiatric care for both the mother while also having the baby present in this, in the same environment. So there are absolutely very limited resources. The few that do exist do need to be better utilized. That's absolutely sure. And also ECT, I'm a firm believer that it's still an excellent treatment of choice, especially for patients who cannot tolerate medications. But tell me, Dr. Raja, Divya, if any of you guys have experienced ECT with your patients. I know that it's not as commonly done, but it is still used every so often.
Fortunately, ECT has even a higher stigma than medications or therapies.
Right.
We see it definitely with our most severe patients, and these are the patients that are already inpatient. And I think that's when ECT will be considered. But from the outpatient world, we really don't see it because of the huge stigma. And I would say that's not a cultural thing. I think it's a very societal stigma that, the media has kind of created, and we really haven't done a great job yet of minimizing that stigma in our community.
Thank you. I think there's another hand raised, Dr. Stella Gandhi. I'm going to try to unmute you. Stella, can you unmute yourself? There you go.
You all talk about the depression, and especially in the South Asian community. My question has a little bit of a twist. Does the incidence of depression occur more with the first child, second child, third child? Is the parity make any difference? And on the lighter side, having a physician, family physician, or a husband as a physician in the house make any difference in the delivery of the children?
I think there's two people who both, go ahead, you're muted.
So definitely the first time moms have a higher risk of postpartum depression. And if you have postpartum depression the first time, there's a 50% risk you'll have it for the second baby. But that does mean that it's not necessarily that you will. So, a lot of moms come in and they say, well, am I definitely going to be depressed this time? I don't want to have another child. And so we have to educate that it's not necessarily the case. And there's no data to suggest that having a doctor in your house, or a psychiatrist for that matter, makes any difference to having these symptoms. But I think probably to awareness, right? And I think it's really important. And the thing that I kind of urge most from all of this is just education and awareness. And I think if we start there, I think having physicians around who understand that this is a highly prevalent disorder that we can treat can be really helpful.
I would add that if we can, if somebody is expressing those worries that what if this happens again, if I'm seeing that person as a client, I would say, okay, let's plan. Let's do some anticipatory work. And we'll talk a lot about what did you experience before? When did you notice them? We'll try to find some patterns. I will be, of course, screening them with the Edinburgh, which, as Dr. Raja said, it's also validated for use during pregnancy. And ideally, OBs will be screening with the Edinburgh. If I'm seeing a pregnant client with a history of depression or anxiety, I will screen that client during pregnancy. I would really want to coordinate care with that person's prenatal provider, with their OB or their midwife. I would make sure I have a release to talk to them and say, let's really get on the same team. I saw a bunch of pregnant moms who were pregnant during COVID and were so anxious. And we made sure that we got the care team together. And we also made sure okay, who's going to come and help you after the baby comes? We talk so much about labor and delivery. It's a finite event. It might be good or bad, but the labor and delivery will end. And then people are postpartum and they're like, I never thought about this. Who's going to cook for you? How are you going to sleep? Who is your lactation person? This is how soon I can see you after you have your baby. COVID is terrible, but doing teletherapy, what's nice is that someone's 4 days postpartum, they came home from the hospital, we can do therapy over Zoom, so I can see them right away. how are you feeling? Are you feeling tearful? So there's a lot of like anticipatory work, and you can really involve moms in the process, and it can feel very empowering for them too.
That's really important. You know, South Asians, I think it's really important also to distinguish, I don't think this came up, but South Asians often also present with different symptoms than the general public does. And I think it's important to remember, again, for those around moms or new moms, to not just look for sadness and tearfulness. There's so many other things to look for. Some of them do present with altered sleep, which is probably one of the most important things, but also other physical symptoms like GI distress, back pain, whatever it may be. And anything that's different needs to be addressed, right? Whether it's discussing it with them, taking them to a provider, whatever it may be. Do we have time to continue, or are there any other questions? Actually, there are a few more questions that are coming up. Let's see. What kind of risks are associated with ECT? So I'll briefly just talk a little bit about that. So the most common risks of ECT actually are anesthesia risks. Most people tolerate the ECT quite well. So they have some muscle aches because you have a seizure during the treatment. So you'll have some muscle aches soon after the procedure, and some headaches sometimes, which resolves with Tylenol. And then the other concerning side effect is short-term memory loss. So you have difficulty creating retrograde memories and maintaining them. This usually resolves within 5 to 6 months. Infrequently, it can be long-term memory loss, but more often than not, the memory loss dissipates. Those are the biggest side effects that people worry about. But just the visual of it, right, from One Flew Over the Cuckoo's Nest or something of that nature, I think is what causes that stigma and is difficult for us to break into that it's okay mode, right? But I agree, I think ECT has an even larger stigma than the medications alone, right? So, but it's important because it's not just for, again, postpartum depression, which this is, it's for all mental illnesses, right? ECT is very, it's a useful treatment. Okay, I'm just gonna mute that. Okay, so I think, so I'm just gonna read some things. I hope there are some non-physicians in this group who will continue to spread this this message, and I agree. I think we have a good combination, and I'm really hoping that this is increasing awareness, and more than anything, improving the ability to communicate with our peers, our friends, our family members, to have this discussion. We don't need to sweep it under the rug, right? This is an opportunity for us to say, hey, I just talked about this, and hey, you just had a baby. How are you doing? It's not, we goo goo gaga over the babies. The newborns are always so cute, but are we also asking the moms how they're doing? Are we taking care of them as well? Are we, remembering that before she was a mother, she was a person? And it's really important to also make sure that we understand the cultural expectations of our society as well. Let's see if there's anything else in terms of, I think we addressed the past history of depression. It does increase the risk of postpartum depression, but again, it's just something to maintain communication with the psychiatrist or the therapist. Is there any, okay, I think that addresses all the questions. Go ahead.
How about other mental illness like anxiety, bipolar? Should we be telling all of our female psychiatric patients to be careful during their postpartum time? I think it is really important just because these are really common disorders too. We talk about postpartum depression much more often just because I think that's what's been emphasized by the media. Postpartum anxiety disorders are very common. In fact, I remember when I was training that we often had women who were just anxious and they had postpartum anxiety, and the EPDS, or that Edinburgh postnatal depression scale, was given to them and they passed it. And so nobody treated them until months later where they were like, I'm not functioning well. And so I think it is really important. I actually have all of my female psychiatric patients who are pregnant right before they deliver. So usually around 32 to 34 weeks, I like to have them come in actually with their partners, and we talk about all the possible things that could happen, just, red flags to watch out for. And their job is not to figure out exactly what it is. It's just to call me with any concerns that they have. And so I think that's really empowering to bring family support on board from there. And I actually ask the spouse or partner to call me after delivery within the first 24 to 48 hours.
Dr. Bakshi, I would like to have some educational material on postpartum depression. We can able to put in the web,
Yes, absolutely. Absolutely. There's also a question about whether postpartum depression runs in families. Dr. Ajay, go ahead.
So postpartum depression can absolutely, depression itself can run in families, but it's not the only thing. So again, this can be a concern for patients who are who have depression or have had postpartum depression. Is this going to affect my child? And we know there is some genetic composition of depression, anxiety, bipolar disorder, schizophrenia, et cetera. And so, it is a question that I ask on all my intakes for women who are of childbearing age, if their moms have had postpartum depression. Actually, Ami taught me that. So I think that it is a very important question, and it can be really telling of, what the risk factors are. So it's not black or white in terms of, if the mom has had postpartum depression, that their daughter will too, but that it does increase the risk.
Divya, there's a question about, or I guess it's more of a comment about the importance of South Asian support groups. So do you know of any South Asian support groups outside of the chat group that you're starting?
I don't. And I also, one of the things, we need more of us. I say that all the time. We just need more and more and more and more. And one of the things that we are working on with the Perinatal Mental Health Alliance for People of Color is to really build a pool of perinatal professionals of color, so folks of color can get specialized training from PSI to be a perinatal mental health clinician, regardless of what your professional background is. And the other thing that we want to do is we want to have, PSI has coordinators in different parts of the country. You call them up. You can look at postpartum.net, find your local coordinator and say, hi, I'm trying to find a perinatal provider in my area. They'll hook you up. We're trying to build out a similar network where we have representatives of the Alliance in different parts of the country so that they are more connected with different resources for different communities of color. And depending on where you live and what your ethnic identity is, you might be tapped in with different ethnic communities, different communities of color. So if we have a South Asian person who lives in a predominantly South Asian community, and I can get them to be an Alliance representative, I might say, hey, can you find all the good resources for South Asian folks in, Edison, New Jersey? Like, can you get me a list? And can we get that up on a website? So we're working on that. We need more. And part of it is like, I was like, God, if we have this group, are people going to come? Are these moms really going to say personal stuff on the internet to strangers? Can we do this?
Right.
What? And I think we're going to do this because we need it.
So no, this is really helpful. I think you're right. There's a need for it, and it's just a question of how can we create it. Apparently, there is a South Asian therapist website that was put in the chat. So hopefully that's something that we can utilize. There's another reminder that postpartum depression is highly correlated to future bipolar disorders. So that is something to keep in mind. Again, all of this, just is a reminder that it's really important to maintain treatment and to keep a close eye on that patient. I'm sorry?
Psychosis is highly related to or bipolar disorder, not postpartum depression.
That's a good differentiation. That's a good point.
I just wanted to make one quick comment. Somebody made a really great comment in the chat about pediatrician screening. I cannot emphasize this enough because we have prenatal care and we go to ROB, you deliver the baby, labor and delivery finite, you go to your 6-week checkup and then what? And then nothing. And this idea, like Dr. Raja said, of in the DSM, postpartum is 4 weeks. No, it's like the first year of your child's life. But we often don't. Come on, who goes to the PCP regularly? And research shows, like during our childbearing years, most women get their primary care with their prenatal provider, right? But you see the pediatrician on day 3, on day 5, 2 weeks, 1 month, 2 months. I used to work at a community health center, and we had integrated behavioral health, and we screened all the new moms. And you know, that's what the gold standard is, to screen at 2 months, 4 months, 6 months. I think it's 9 as well, but to screen routinely in pediatrics. So if anybody wants to integrate that into their pediatric practice, the tricky thing is then if you screen, you got to know where to send the moms. But that's when you call PSI and you say, hey, where can I have somebody who scored a 12 on her Edinburgh. But pediatricians, that's where the moms are most of the time.
Yeah, that's absolutely a great reminder. I think there's a couple of people who've talked about this now, but the importance of depression, not just after the prenatal period, but also during menopause. So just the hormonal the times of hormonal fluctuation. Do either of you guys want to address that and how that impacts women later in life? Okay. Divya, go.
Harita, do you want to take that?
Oh, okay.
I can take that. So what we know is that in perimenopause, and Stella had actually asked in the chat as well, we do know that there's a change in estrogen. So perimenopause is actually the time that women generally who have had regular periods are now going to get abnormal periods. So they're coming at different times. And what we know is that these women have a higher vulnerability for symptoms during this time of perimenopause, especially because the estrogen is dropping. And so again, when we look at etiologies, there is something about hormonal shifts and being sensitive to hormonal shifts. And so sometimes we'll see women who have really struggled with what we call premenstrual dysphoric disorder, so around their periods, then they've struggled in, postpartum or during pregnancy because of hormonal shifts there, and then during perimenopause. I can make a huge shout out to my mom right now, because before I was, an expert in this field, my mom went through perimenopause, and I said, just get over it, Mom. Wasn't very nice, but I can tell you she struggled, and she struggled because nobody talked about it. And so I think the best thing we can do for, again, our families is just to talk about what's normal, right? It's normal to have many different symptoms during perimenopause. It's not just depression and anxiety, and I think it's just important to normalize what's normal and then to treat what's not. So I love you, Mom. I'll be better next time.
I don't think they go through menopause more than once, but, I think there is this element of passion that a lot of people in this group have experienced. And a lot of that stems from the fact that if you haven't experienced it yourself, somebody who has. This isn't something that is rare. This happens often, right? But we're just, again, we sweep it under the rug. Almost 20% of new moms are experiencing this, but more than half of them are undiagnosed. So there's clearly a need, and I think we're all saying the same thing: the importance of recognizing these symptoms and addressing them is really key. There's another question about how long the postpartum period can last. Do you want to address that? I think we'll make this the last question and try to stay within that hour period.
So postpartum depression can last varying times. And so, it's really about getting women treatment as soon as we can. And we say symptoms can start in the first year, but women who are untreated, this can go on for years. It can be a very difficult process. Other women who get treatment sooner, they may be better in weeks to months. So it's a very, it really varies by person, and we don't have an exact time for how long it would last for an individual.
Okay, and on that note, I'm gonna stop our conversation here and really thank everybody for joining. We've really appreciated the back and forth and the ongoing conversations and people's excitement about this, because that was ultimately our goal. Our excitement is because we want to share this with the community. Divya, thank you for sharing about the cultural components, because that is so important. This isn't just about our, the postpartum depression. This is really about how can we help our community as well. Dr. Raja, thank you for sharing the medical components of it, because the docs here need to recognize when we need to refer patients, when we need to take things seriously, but all of us also just need to recognize this in our, the people that we meet on a day-to-day basis, right? And Priya, and I can't thank you enough for, sharing such a raw piece of your life right now, with not just, a small group of us, a relatively large group of us, putting your story out there for the world to hear, something that more and more people are trying to hide. It's so important to be able to share this, and I can't share with you how thankful I personally am, but I know this group is, for you to come out here and so humbly share your experiences. And I know that, I think some of your family members are on this, and to all of them, not only are we sharing our deepest condolences, but we also really want to share our appreciation. You guys are just doing such a great deed in honor of your sister, and we're very thankful. So thank you.
I just wanted to, again, thank all of you for having us, for letting us use your platform to share her story. The only thing I can ask for is, since I see that most of you are physicians, or this is the physician group, I know in our Desi culture, anytime someone brings up doctor, whatever they say is of highest advice people want to take in and actually listen to. So if you guys can just do stuff in your your language is, so that a broader community, this message is perceived by a larger community, that would be so good. Because we've been trying to, for my own parents, we've been trying to get a lot more Gujarati resources. We're Gujarati, but I know a lot of people don't understand all the terminology, like in these complex, they've never heard of these things, so it hits them differently if it's in their own language, in their native languages. And thank you. I want to say thank you for the scholarship. I just, oh gosh, I have no words. And for the every Monday, the chats, and so much has been done in such a short amount of time. And her story has reached so many ears, and we're just so grateful. We're very, very grateful. So thank you, all of you. Thank you so much from the bottom of all our hearts.
Thank you.
Thank you, Priya. Thank you to all the Bhaktas who are here. So on that note, I believe Dr. Sajni Shah is on the call as well, and she had a few things she wanted to say. Sajni?
Yep, thanks, Omi. This was just phenomenal. I just want to thank everybody. I am a mom of two. I'm also Gujarati, and this is a conversation that needs to happen more often, and as many people as we can reach, because we're expected to sort of do everything. We're expected to run the household, take care of our husband, and have kids, and sort of not sort of blink an eye. And if we do, we're a little bit, it's a little bit of taboo to sort of share that with anybody. So I really want to commend the speakers, Priya, Divya, Dr. Raja, really for coming today and sharing your story with us, because the best thing that we could do with this conversation today, which was so fruitful, so engaging, so helpful, is that we spread this and multiply this, because mental illness is definitely getting more recognition, but it still has more to grow in the South Asian population, especially with postpartum depression. So on me and the team. This is so impressive. I'm so proud of this hour because I think you've accomplished so much, and I really appreciate everyone for, the chats, the questions, the engagement. This is phenomenal. So thank you so much for letting us be part of it tonight. Thank you.
Okay, if nobody else has any other questions, again, thank you so much. And for those of you asking about recordings, the recording of this session will be on API's website, which is open to the public at this time. So whether it's you or if somebody else is interested, please do send them over to API's website where they can view the recording of today. And if anybody's interested in the slides, I'm happy to share those as well, okay? Thank you so much, everybody. Have a good evening.
Thank you, Dr. Raja. Bye-bye. Thank you, Amy. Bye-bye.
Bye.